Okay, so I will pass you over to Poe, who is going to introduce this month's speaker. Thank you very much, Poe.
Yes, thank you. Thank you, Selena, and thank you, Rachel. And thank you, Zhiqiang, for agreeing to be our September 2025 speaker. So it is really a great pleasure for me to introduce to everybody Dr. Zhiqiang Yuan, who's um, actually a great collaborator of us, a great friend of the Iowa team, and who has done many years of research in the neuroendocrine tumor field. He is currently an assistant professor at Rutgers University in the Department of Medical Oncology. He received his medical training and residency training in China. He subsequently did his postdoc and fellowship at McGill University in Montreal, Canada, and then in Albert Einstein College of Medicine in New York. So his research has received funding from the NETRF, and currently he's actually a major key investigator of our neuroendocrine tumor spore, Project One, with Dr. Quell, and working on immunotherapy for neuroendocrine tumors. So this is an area that is like really exciting in neuroendocrine tumors. So we thank Dr. Yuan so much for giving up some of his time to give us this lecture and to kind of give us an introduction. A lot of our students are actually new to this field, so we look forward to hearing your exciting talk, Shishang. Thank you.
Thank you, Paul. So today, my talk is the title is the role of the B7X signaling pathway in the progression of the pancreas neuroendocrine tumors. So we know the pancreas neuroendocrine tumors increase in the extent, and also the understand the tumor type with limit treatment option. Uh, there is an urgent need to understand the pathogenesis to develop a new therapeutic strategy. So immunotherapy is a type of a cancer treatment that use the patient's own immune system to fight cancers. It works by enhance the immune system's ability to recognize and destroy the cancer cells. There are several different types of the immunotherapy, including the checkpoint inhibitors, adaptive cell therapy, and such as the engineered T cell therapy, and also have a cancer vaccine and CAR T cell therapy. So today my talk is focused on checkpoint inhibitors and also adaptive cell therapy. So the B7 families and the receptor of the CD28 families are the major immunocheckpoints that regulate T cell activation and function, which make their pathways very attractive targets, such as the PD-1 and PD-L1. We have discovered two new members of the B7 CD28 families, B7X and HLA2, which are involving enhanced cancer development and progression by inhibitor T cell immunofunctions. So use our human tissue bank, we demonstrate that the immunocheckpoint B7X is a expression in the 60% human PNAS. In stage 1 PNAS has a 54.8%. In stage 2 have a 57.5%. In stage 3 is a 75%. In the stage 4 is a 100% overexpression B7X. So we also demonstrate there is a significant correlation between the B7X expression with tumor size and the tumor cell population by Ki67. In the panel A, we can see the human PNET tissue have overexpression B7X, and the normal pancreas tissue without the B7X expression. So in the panel B, the images show the B7X positive is a correlation with the tumor size, and also the B7X overexpression also correlation with the Ki67. We also use our mouse model and see how about the B7X overexpression. So we developed the MEM1 knockout mice by knockout MEM1 gene in pancreas tissues, and these MEM1 knockout mice can develop insulinoma in the pancreas, and with our high insurance. We can see B7X is also overexpression in the PNET tumors of the MEM1 knockout mice. So we also cross in the B7X knockout mice and MEM1 single knockout mice and generated the B7X MEM1 double knockout mice. We can see the insulin is a tumor biomarker of the insulinoma in the MEM1 B7X double knockout mice. The insulin is a significant decrease in the MEM1 B7X double knockout mice compared to the MEM1 single knockout mice at the different time point. We also see the H is stating we can see the islet is much smaller in the MEM1 B7X double knockout mice and compare the MEM1 single knockout mice in the panel B. So we also use the immunopanel of the flow assay. We can see the T cell infiltration in the MEM1 B7X double knockout mice compared to the MEM1 single knockout mice. And you can see the image, the CD4 positive cell, CD8 positive cell, NK cell, dendritic cells is increase in the MEM1 B7X double knockout mice compared to the MEM1 single knockout mice. So we developed the B7X antibody, and we use the B7X antibody to treat the MEM1 knockout mice with the insulinoma. In panel A, we can see the insulin is significant decrease in the B7X antibody treatment mouse to compare to IgG control mouse. And also in panel B, we can see the survival is improved in the B7X treatment mouse compared to IgG control mouse. In panel C, we can see the T cell also infiltration in the double knockout mice compared to control in the B7X antibody treatment mouse compared to IgG control mouse. Yeah. So we want to understand why the B7X in the development of the PNES. So we found the H1 alpha's overexpression is associated with the upregulation of a B7X in the tumor microenvironment of the MEM1 knockout mice from the 6 months and the 12 months because the tumors are growing so quickly and make the hypoxia in the tumor, and the tumor cell or also the make the H1 alpha's overexpression and make the B7's overexpressions. So in vitro study, we also found the HIF1 is a regulation the B7X expression under hypoxia condition in the in vivo study. So we use a M134 a mouse penis cell line. We culture it hypoxic condition. We can see that both HIF1 alpha and B7X overexpression under hypoxia condition. And in the panel A2, we can see the HIF1 alpha and absent, and the B7X also absent when we treat the cell line with the xRNA, knock down the HIF1 alpha under hypoxic condition. In panel 3, we also found the B7X is increased transcription when the under the hypoxia condition by the Lucifer assay. So in panel B, we can see the HIF1 alpha also can bind to the B7X promoter in the M134 beta cell line and the MEM1 tumor tissue of the MEM1 knockout mice by PCR assays. So we also developing the MEM1 HIF1 double knockout mice by crossing MEM1 knockout mice and HIF1 alpha knockout mice. We also see in panel A the insurance decrease in the MEM1 HIF1 alpha double knockout mice and compared to the MEM1 single knockout mice. And panel B, we can see the islet is much smaller in the MEM1 HIF1 double knockout mice compared to the MEM1 single knockout mice. And the panel C, we can see the Ki67 is a decrease in the MEM1 HIF1 double knockout mice compared to MEM1 single knockout mice by IC staining. So we also use the IC detect the B7X in the MEM1 double HIF1 double knockout mice. We can see B7X expressions are absent in the MEM1 HIF1 double knockout mice compared to MEM1 single knockout mice. We use the flow assay. We also found the MEM1 HIF1 double knockout mice have the increased T cell infiltration compared to MEM1 single knockout mice. So we also cooperation with the NETChatter, one clinical stage company, and want to develop some engineered T cell can target for the immune checkpoint for PNET treatments. We know that NETChatter is a good clinical stage company. They developed a novel approach for targeting immune response by use a different antigen specific T cell. So we cooperation with them and identify some tissue the tumor specific antigen driver by B7X and HLA-A2 and developing some HLA-A2 engineered T cell for target B7X and HLA-A2 tumor cell. Because we use HLA-A2 is HLA-A2 is most common HLA type in the population in USA. So we cooperation with them and use this specific tumor antigen to stimulate the T cell and use this engineered T cell to treat human PNET cells. These human PNET cell, they are all expression for the B7X and HLA-A2. So we use our in vitro and in vivo model for test this engineered T cell. So the first thing we check the HLA-A2 in some PNET cell and other kind cell. We found the BOM1 cell is an overexpression HLA-A2. We also found the BOM1 cell also is a HLA-02 allele positive. So we use this bond cell line for check our the engineered T cell is a anti-tumor response. So another Helic 293 for negative control because Helic 293 is a HLA2 negative and also have HLA2 positive. So we use the HEAK 293 is for the positive for the negative controls. We developed two different kinds of engineered cell. One is a HM1, another is a HM2. So if we use two different engineered cells, T cells. So in vitro study, we do the T cell killing assay. We found use this targeted T cell within the bone cell culture, and the bone cell is significant decrease and compared to the HEK 293 because the HEK 293 the cell is still growing without the T cell cultures. So next step, we do the in vivo study. We put the bone cell into the new mice, and after day 14, we inject the T cell. Another 3 dose IL-2 for the 3 days. After the 28th day, we collect the serum and tissue. And for the PBS, we use for the controls. And T cell, before the injection, we culture with the cytokines in the 2 to 3 days and make the T cell more active. So in the panel A, we can see the day 50 after the post-treatment, the T cell treatment group, the tumor size significant decrease compared to the PBX group. And also the tumor weight is lower in the T cell treatment group compared to the PBS group. So panel C, we can see the tumor the size in the T cell group and the PBS group. We can see the significant decrease in the tumor size in the T cell treatment groups. So in the Ki7, we also see the T cell treatment group, the Ki7 positive cells, a significant decrease in the compared to the PBS control groups. So we also check the apoptosis status by the tunnel assay. We can see that in the T cell treatment group, the apoptosis cell is a significant increase compared to the apoptosis cell in the PBS groups. So we also are staining with the caspase-3 apoptosis marker. We can see the caspase-3 is a significant increase in the T cell treatment group compared to PBS treatment groups. So we also use IFC and flow and check how about human CD3 cell because this is a human T cell is a human T cells. So we use a human CD3 biomarker. We found in the tumor tissue they have many T cell in the tissues, but not in the PBS control groups. And we can see the flow assay if a very high the CD3 positive cell, CD8 positive cell, and CD4 positive cell in the T cell group, not in the PBS groups. So the summary, from our data, we demonstrate that in the B7X and HLA2 is highly expressed in the human penis and correlated with the tumor aggression. And also we saw the HIF1 alpha expressions are regulation immunocheckpoint, promoting the suppressor within the PNET tumor microenvironment. To explore treatment implication, we assess the potential of the target B7X with anti-B7X antibody and engineer T cell to monitor the tumor microenvironment. So we found the provider, we are findings providing insights into the role of immunocheckpoint in the PNET progression and support the development of novel target immunotherapies for the PNET patients. So our ongoing study, we continue developing GMP-grade B7X antibody and engineer T cells for use in the clinical trial for targeting human PNETs for enhanced immunotherapy in the human PNET microenvironment. For further, we will continue identify more novel T cell based and NK cell based immunocheckpoint through single cell RNA-seq assay of the tumor microenvironment of PNETs. And we also want to discover the novel tumor specific antigen used for TCR sequencing and BCR sequencing for the treatment of the human PNETs. So thank you. We also acknowledge and different people from our Cancer Institute of New Jersey, also some PI from the Albert Einstein College of Medicine. We also thank you Jim and Tom and Paul from the Iowa University of Iowa to support our research, and also thank you NETChatter provide some engineered T cell for our study. So all our research support by the Neuroendocrine Tumor Research Foundation and also the NIH NCI grant and also the NETChatter Immunity Research funding. So today I will thank you all people to attending, and I'm happy answer any questions.
Thank you so much. That was an excellent presentation. Before I start asking any questions, does anyone else have any questions?
I do.
Yes.
Yes.
So very lovely presentation, Ziqiang. Thank you. When I am going through, I have a couple of questions, sorry. The first one is in your MEN1 HIF1 alpha knockout, double knockout mice. The islets look really small at 12 months.
Yeah.
But at the end of your, I guess it was in either the size of the tumors or an insulin measurement, it looked like it was starting to come up. So I wondered if you monitored those mice longer, would they develop tumors, but just in a much delayed fashion compared to MEN1 knockouts?
Yeah, we will see the longer till to the 15 months. We also cannot see the insulinoma and hyperplasia in the MEN1 HIF1 double knockout mice. So I also now I also cross the more aggressive the mouse within the MEN1 P10 double knockouts and get the triple knockouts, and want to see this triple knockout can prevent the tumor development or metastatic. So now I still monitor for the triple knockout mouse.
I see. Wonderful, because I was going to ask that next. So that's really great. Thanks for anticipating that.
Yeah.
I had one more question, and it's about your engineered T cells.
Yes.
And I guess somebody walked in my office and we talked for a minute while you were presenting some of that data. So when you do the treatments, you had the BON1 xenograft model, or were they the MEN1 knockout model?
No, it's only for the bone cell graft model because it is a human cell
Okay.
line. So,
Okay, got it. Okay.
yeah.
And these are human T cells that you've
Yeah.
engineered.
Yeah,
Uh,
because also the company, they don't care the
they don't
mouse
want to make a
study.
mouse.
Yeah.
Yes.
Yeah. Because
That's
they want to do the human study. Yeah.
Yes, so true. So what I wondered is, are you working toward having organoids or patient-derived organoids that contain a variety of cells that you would test your engineered T cells on?
No, I don't did that part. Yeah.
Yeah, I know you would need to make a very complex
Yeah.
organoid for this to be in any way useful. I was just wondering if there's any way to try and get it out of the animal and to do something, given NIH's desire to decrease all animal work and do liver on chips and all these other things. I was just curious what you were thinking.
Yeah, and also the user new mice, they have a limitation because there's a immunosuppression mouse.
Yeah,
So,
exactly.
so we want to want to do the normal mouse in blood six. So the first thing we want to identify some the tumor antigen from the MEM1 knockout mice. So we are working for that and want to see how about uh, some the tumor antigen from the mouse, the normal mouse, and after use the engineer T cell, mouse engineer T cell to treat the mouse. That's more normal for the mouse because
Yeah,
they don't have the immunosuppression.
exactly. Yeah. Well, fantastic. Thank you, Zhizheng.
Yeah.
Wonderful. Samira, did you have a question?
Yeah, I obviously someone very smart already asked some of them. It was about the human T cell receptor. I was wondering, since you're using in part mouse models and mouse cell lines, and so thanks for answering that question. Beautiful presentation. It's always exciting to see new avenues for finally having some immunogenic responses and seeing that. My actual second question refers to, you alluded to seeing a little bit of grade difference in your initial stains. And since some of these models that you're using were either high grade or low grade in terms of Ki-67, did you see responses? And we again, the knowledge is limited, right? The immunogenicity and presence of immune cells, it's thought to be depending somehow still on kind of grades of these tumors and how they would respond. So have you seen any, with regards to grading?
Yeah, but from the MEM1 single knockout mice, it's a low grade insuloma.
So
Yeah,
that's a
we also
more
have the high grade knockout mouse model. There's MEM1P10 double knockout mice. These knockout mouse, they
so that will
have
be high
a
grade.
really aggressive mouse model with the metastatic. So next step, we will cross our the B7X with the P10 MEM double knockout mouse and see they can change the phenotype in the uh, high-grade mouse model. And we also have the B7 antibody. We also can use this antibody to treat the high-grade mouse model and see they can inhibit the tumor cell proliferation and the metastasis. The next step, we will translate to the high-grade insuloma mouse model is the MEMP10 knockout, double knockouts.
Excellent. Yeah, thanks a lot. And I think to the previous person asking, I encourage you to use some of now hopefully going forward NIH's new resources and maybe some models coming. That would be really great for your work.
Yeah.
Thank you.
So why we use the engineered T cell target for the HLA A2 and the B7 is because somebody they use a CAR T, SSTR CAR T. But SSTR CAR T, the problem they have some normal tissue expression the SSTR CAR T. SSTR2 expression. If you use the SST2 CAR T, I believe they have very high toxicity because SST2 CAR T, they will also target the normal tissue. So in the HLA2 and B7X is very, very low expression in the normal, almost not expression in the normal. So we use the B7X and the HLA2 engineered T cell. We can very limited the side effects. So we make the engineered T cell for the target for the B7X HA2s and let the toxicity decrease there to compare to the SST2 CAR T.
Wonderful. Do we have any other questions?
Oh, I have one. Nice to see you guys.
Hello.
And hello. And I'm just curious, and I have two questions. And one, you're using the bone one, and I saw the tumor. That's also topical or just sub-Q?
Because we check the many PNET cell, only bone one have a HA2.
I understand. Yeah. I just want to know if this is just the mimic the tumor grow in the pancreatic or just sub-Q and
sub-Q. That's sub-Q.
Sub-Q, right? Okay. That's okay. The first, I really impressed all your work, and thank you. And the second one, and I look at and the one I just curious. And one slide, you said, you do the double lockout, HIF1 alpha and the MIN1. I saw all this immune profile. How come the Tregs and also increase in the double lockout and along with the CD4, CD8, NK or these T killing cells? That's my question. And Treg, my experience is just, the function is just, So I saw your Treg also is up.
And HIF1, MEM1 double knockout, they also see the T cell infiltration, maybe the less tumor cell. Yeah.
So the Treg cells also up, also increase in the double lockouts and with the CD8.
Yeah.
Oh, that's interesting.
Yeah, that's a yeah. So this I also want to understand why. Yeah.
Okay, and also the microphage, you just using the marker. You didn't identify as the tumor associated 1 or 2 or because the function is kind of opposite. So you're just using I forgot the marker is the one marker you're testing, right? The microphage. Oh, okay.
Yeah.
Okay.
So HIF1 have so many pathway. So maybe it's not only the pathway for involve B7X. Maybe they also involve the VGF or also some and also the immunocheckpoint other pathway. Yeah.
I think there are a lot of mysteries here.
Yeah.
Thank you so much.
Yeah.
For sharing your results.
Thank you. Any other questions for our speaker? I had a quick question, and you may not know, but the answer, because you guys may not have looked at it yet, but this was an excellent presentation, and I really liked your work on HIF1 alpha. I can't help but bring up HIF2 alpha because of all of the recent success in the field, especially with VIOs and paras with belzutifan, which is a HIF2 alpha inhibitor. Is it too far of a jump in my mind to say if a patient's responding to maybe HIF2 alpha inhibition, would that suggest maybe they have a more of an immune infiltrate into their tumor and they may also be candidates for immunotherapy? Or maybe we're not really at the point to be linking the HIFs to immunotherapy just
Yeah,
yet.
maybe next step we can check HIF2. And why we use HIF1 alpha? Because we found some group they have the evidence, the report HIF1 alpha also bind to the PD1, PDL1 promoter, because a HIF1 alpha is a transcription factor. They binding so many gene. And so we found some paper, they report the HIF1 alpha also can bind to PDL1 promoter. So we use the HIF1 alpha to check that they can develop the relationship with the B7X. So we found that they can bind that and also associate within the B7X overexpression. Yeah.
That makes sense. That makes sense. Thank you.
Yeah.
All right. Any other questions from anyone? All right. Well, I guess we can wrap it up here. Thank you again so much for giving this presentation. I think I can speak on all of us, and we're very grateful and thankful for your time. And thank you to everyone who has attended and tuned in today. We really appreciate it. It's great to see you all this month. Selena, do you want to add anything before we end?
I don't think so. I think you've said it all. Thank you very much for giving us your time, and thank you for all the great questions. It's great when it just makes lots of discussion and makes it all worthwhile. So next month, I think that we will probably move forward to the beginning of November and try and coincide with Neck Cancer Day. If anyone's got any patients that they think might like to tell their story, then that would be great, because we are always on the lookout for patient stories all the time. I think it's great when we can hear from the patients themselves. I don't think a lot of us, especially researchers, we don't really get to hear the patient stories very often. So sometimes, I think that can be quite interesting, going right back down to base level with the patient. So if any of you do have any patients, send them our way, it would be great. But otherwise, thank you very much. Thank you, Rachel, for hosting. Thank you, Po, for your introduction. And thank you so much for giving us your time for this presentation. It was fantastic. And hopefully we will see you all again next month. So thank you very much. Thank you. Thanks.
Thank you.
Bye-bye.
Bye.
Bye.
Thank you. Bye.